Welcome and thank you for joining us for tonight's webinar, Primary Care Providers in the Disaster Response. My name is Sydney and I'm from the PHN Education team. I'm joined tonight by Ellen Senf, Josh Emanuel, and Ian McCarthy. Before we begin, I'd like to acknowledge the traditional custodians of the land that we're all meeting on tonight. For myself on the Central Coast, that is Darkinjin country, and I'd also like to pay respect to elders past, present, and emerging. Now, a few things to let you know about this session. It will be recorded and available for you to view in our education library, along with a copy of the PowerPoint presentation slides in a few days' time. As attendees, your camera and microphone are automatically disabled. However, if you have any questions throughout the presentation, please pop these through in the question box, which we will find located within your control panel. And they will be answered at the end of the session. An evaluation will come to you directly after the session. Your feedback is extremely important to us as it provides us the information to put on more education sessions. And a reminder that this session is accredited with RACGP for 1 hour of educational activity. Now I'll hand over to Ellen Senf.
Good evening, everyone, and welcome to our webinar for tonight, Primary Care Providers in the Disaster Response. Thank you for coming together tonight. Before we start, I would like to acknowledge the traditional custodians and the country, the lands that form our region, and the ancestors past, present, and emerging. We acknowledge that Aboriginal and Torres Strait Islander people are Australia's First Nations, and we recognise that these lands never were ceded. And the PHN also recognises their unique cultural and spiritual relationships to the lands, water, and seas. We acknowledge the rich contribution to society and the traditional knowledge First Nations Australians have to offer to us and our future generations to be the turning point of reconnecting humanity with land and culture. So, before we kick off, I just want to give you a short overview of the contents we will cover tonight. We will talk about the role of primary care providers in the disaster response, the role of the different entities, PHN and the local health districts in the disaster response, what the Primary Health Network Emergency Register is, evacuation centres, how they're set up, what to expect, how you can assist the primary care response in an evacuation centre, and how the coordination before, during, and after a disaster event would work out. John Bailey was planning to do a short introduction for you tonight. He's the Executive Manager, Primary Care Improvement. However, he could not attend tonight, but we will have it covered. So the disaster management cycle, probably heard about this. It's about preparedness response, recovery, and prevention and planning, and how these different stages are interlinked. There are different elements to it, and primary care providers, they're important pillars of their community. They're inherently involved in all phases of the disaster management cycle. There are some inward facing for the business aspects and outward facing aspects. That's about patient and the community supporting activities. And it's a continuous process with each part building onto each other. It's also subject to continuous review, so we always want to include lessons learned from the last event to make the response and recovery from the next event better. The RACGP has been very busy and has worked a lot on defining where primary care providers should sit. Provided an advocacy statement only recently called The Role of the General Practitioner in Disasters and Emergencies. I put the links of all documents I refer to into the slides, and it's definitely acknowledged that primary care providers, they're always one of the first points of contact. They can offer continuity of care for patients with chronic conditions. They can prevent exacerbations during disasters. GPs, they're a constant healthcare service present before, during, and after a disaster. Offer comprehensive and holistic care, addressing physical, mental, social health needs, and that's really crucial in disaster situations. They offer preventive care and health education to reduce the risk of disease outbreaks, for example. And they're also really importantly involved in the coordination and integration with other healthcare services and community resources, ensuring a seamless and integrated response to disasters. Primary care providers are involved in emergency preparedness planning, and they can quickly mobilize to provide care in various settings. They also offer mental health support and public health surveillance, like psychological first aid, mental health support. If there's an outbreak of diseases, they're the first point who would see such an outbreak and can report it to the public health unit. And primary care providers are involved in building the community's resilience by providing consistent and reliable care and enabling a quicker recovery from disasters. Also, you educate the community on disaster preparedness and health maintenance, so that empowers individuals to protect their health. There's a rationale why we developed the Primary Health Network Emergency Register. So first of all, there was a recent change. Primary health networks have been included in the New South Wales Health Services Functional Area Supporting Plan. They act as first points of contact on primary healthcare coordination matters and service availability during emergencies as part of the overall coordinated response. PHNs coordinate preparedness activities, communication and mobilization of services offered by primary care providers at the local level, and communicate service availability and needs to address current or expected demand, supporting better overall whole of health system organization of services. There's also the rationale that we have seen what happened in past disaster situations. And one example is a catastrophic event that unfolded in Lismore in 2022. There were over 30 evacuation centers open. It was quite chaotic. Lack of coordination meant that providers who were willing to assist were turned away at some evacuation centers due to that lack of oversight and coordination. So we really have to prepare for major and large-scale catastrophic events. There's a saying in Latin, si vis pacem para bellum, which means if you want peace, prepare for war. While we're not talking about war, catastrophic events might look like war when you look at the footage from there. So we really have to make sure that that's covered in our maximum preparedness. The Primary Health Network Emergency Register, we developed a handbook. We worked together with many stakeholders to put this together for you, to give you guidance and structure and some coordination. Thank you to South Western Sydney Primary Health Network, who developed the scaffold, who developed the first of these handbooks for their region. They kindly let us individualize it for our Hunter New England and Central Coast context. And we worked with the Hunter New England and Central Coast local health districts. We received feedback from GPs, feedback from GPs who were recently on the PHN Emergency Register, and also from the Department of Communities and Justice. As I said, structured approach is our goal, to give you an overview over the command and control structures, the models of support, in scope, out of scope activities, training, debriefing, and insurance and remuneration topics. The next slide will be an overview how AI depicts primary care providers in the disaster response. I often use AI when I put slides together, and this application put exactly together what we don't want to see when a disaster unfolds. I will show it to you because it has some value. You will see it's absolutely what we don't want to see when a disaster event evolves. First of all, it looks quite unsafe. There's structures collapsing in the background. Also, it doesn't look very well coordinated because we have like 20 providers on the ground and they're all staring at one patient. And then we also have some out of scope activities going on here. It's a baby and a missing limb. So that's definitely nothing that we see primary care providers providing in an evacuation center. Now, going back to the slides, walk you through the two models of support that we have. There's an in-practice support model, and that's the preferred mode of support. You work best within your practice. That's where your support structure is, and that's where you work best and have all the computers you need. You have all the systems in place. You have your staff. Insurance questions don't arise because you're in your own four walls in your practice. So in the practice support model, the LHD would activate the primary health network to coordinate support, and then we would reach out to providers to see who can assist. And we would then also confirm your capacity at every event and reach out who would be available to provide this in-practice support assistance. This basically means upscaling to develop some short-term surge capacity to welcome additional patient load. And that can be patients from the evacuation center or patients from an overcrowded ED who are well enough to be seen by a GP. The next model of support is the evacuation center support model. That would be something that comes into play at some major or catastrophic events. Again, the LHD would activate the PHN for the coordination of the support, and we would then reach out to providers to establish their capacity and their availability. We would then roster, brief, and then provide you with some go bags we put together. The contents of the go bags, if you're interested, they're available in the appendix of the handbook. You can see what's in there. We have them positioned in our offices, so in strategically important areas, Tamworth, Armidale, in Erina, and in Newcastle, and we can bring them to sites when needed. Then we also look after remuneration per hour for evacuation center support, and GP services in an evacuation center that will be required are usually services you also provide in your own practice. Once you're in an evacuation center and you have a patient there who needs additional support, there are referral options. You can refer them to your practice, to another practice who's operational, or if they need to hospital or to other services. And after your deployment and support in an evacuation center, the PHN also looks after the debriefing process. I will now hand over to Josh from the Central Coast Local Health District.
Thanks, Ellen. Sorry, just getting the camera back on again. Thank you, everybody. As Ellen mentioned, I'm from the Central Coast Local Health District. I'm the disaster manager in our district. So I'm just going to run you very quickly through the role of the local health district in a disaster and see where we fit in the whole disaster response scheme, as well as where the PHN would sit as well. So I think, Ellen, are you controlling the slides still? Wonderful, thank you. So when we look at an emergency incident that's happening, so we're looking more at an incident that is actually happening and is overwhelming the resources of whoever is in charge of that incident. So when we look at the New South Wales arrangements, we look at what is known as a combat agency. And a combat agency is defined or identified in the State Emergency Management Plan as the agency who's responsible for controlling that particular response to an emergency. So as you can see on the screen, there are several different organisations who are identified in the State Emergency Management Plan as a combat agency. So they're agencies such as a lot of our emergency services. You recognise there being Fire and Rescue, New South Wales Police, Rural Fire Service, State Emergency Service, particularly here on the Central Coast, in the northern part of the Central Coast, and I'm sure also in a few areas in the Hunter as well. The Volunteer Rescue Association is also a combat agency for rescue. And then we look at some of the other slightly less known agencies such as Marine Rescue, the Port Authority, Department of Primary Industries, and New South Wales Health are also listed as well. We are listed as the combat agency for something that we all are probably well aware of, may have happened in recent times, and that is a pandemic. So we are the responsible agency in charge for a pandemic. In the event that there isn't an emergency situation where there is nobody who is identified previously, then it's managed by what's known as an emergency operations controller, and I'll go through that a bit later on. The second area that's mentioned within the emergency management plan is a functional area. So these are areas that will not necessarily be taking the lead in an incident, but will be supporting the combat agency in managing that incident or emergency. And they'll be helping in all areas of what Ellen mentioned before around prevention, preparedness, response, and recovery. They're all typically government agencies as well. And as you can see there, places like engineering, environmental, health is one of the few. There's about 2 or 3 agencies that are actually both a functional area and a combat agency. It is not particularly common for that to happen, but we sit in both sections there. Welfare services is another big functional area that is obviously very much utilised during times of disaster and emergency, particularly when it comes to evacuation or isolation of communities. There's a huge workload on the welfare services there. Thanks, Ellen. So I mentioned before about an emergency operations controller, and this is a very important position which is legislated, again, within the State Emergency Management Act, as well as looking at the M plans as well. And this position is a delegated position which will always be a police officer at a local, regional or state level. But the difference is that when they go into their role as an emergency operations controller, they essentially no longer become a police officer and they become the emergency operations controller. So they hand their district or their region over to another officer to manage for them, and they then become this emergency operations controller. And colloquially known as a LEOCON, when you're looking at a local government area or a local district, a REOCON managing the region, typically an assistant commissioner, a deputy or assistant commissioner, and then the CEOCON is the state emergency operations controller. And again, that's a high-level police officer who has got vast experience in managing incidents. When they are activated, they also then activate an emergency operations centre as well, which is either a local level, a regional, or a state level. Putting that into health terms, we typically have a health facility controller who manages incidents within a health facility. We then have our LHD or specialty network, HASVAC. So HASVAC is a health services functional area coordinator, and they oversee the health deployment and resources in an incident within their LHD. And then we have a state HASVAC as well, who oversees all of health if it is a larger incident that requires more than one LHD to be engaged or to be utilised during an incident. And to the side of that, we have all of our state health controllers and advisors, which will be on our next slide. Thanks, Owen. So, as I just mentioned, we have a range of state controllers and advisors. There was a recently newly published Health Services Functional Area Supporting Plan that was published just in the last month. And it changed some of the terminology in that. Moved previously there were a lot of controllers listed, but it was deemed that to better terminology to use for their positions was to split them into controllers and advisors. So controllers are now areas that can manage an incident by themselves, whereas advisors would, as the word sort of points out, would be the ones to provide advice to the HASVACs or the state HASVAC in regards to an incident. So ambulance can control their own incident. Public health can also deploy and control. Health share is a new one, as well as e-health around controlling their own incidents, and so is pathology, with the remainder of the positions being advisors now, because they don't deploy staff, they don't manage resources, they provide that advice to the LHD. And as it says there, where possible, we always try and operate at the local lowest possible level. So if it can be managed within an LHD, that's where we stay and leave control there. But if it needs to escalate, then it obviously will to either a site, district or state level. But we try and manage it as low as possible to have that local knowledge available during an incident, because that's the most crucial information can be from the locals on the ground. When we start looking at how we would work with the Primary Health Network, and I've taken this lovely snapshot from the document that Ellen was referring to earlier around how we will work. So when we're looking at that local level, as I said, that's where we always want to try and operate as much as we can. Then we will be dealing directly with the PHN from an LHD perspective, and they'll be working with the GPs and the different groups within the PHN around the type of support that's required for this emergency situation. If there is a state level operation occurring and the State Health Emergency Operations Centre is activated, then there may be a liaison officer in that room as well, which would help getting some information up to the state level. And as you can see there, information flow backwards and forwards in all directions, but streamlined as well. So we're not necessarily getting individuals having those discussions with the LHD. They'll be done through the PHN, either the CEO or Ellen herself, depending on what the arrangement is at the time. I will talk very quickly about evacuation centres because I don't want to steal Ian's thunder a bit later on when he goes into them a bit more. But essentially, looking at the health role within an evacuation centre is to coordinate the provision of health services, primary health services, mental health, first aid and public health. So that may be through the deployment of our own staff, but typically that is one of our last resorts due to the fact that our staff may either be impacted or be required in the hospital setting to provide treatment to evacuees or those affected by the emergency. Within the health services functional area plan, we do have listed St John Ambulance as a participating organisation, supporting organisation, as well as the primary health networks. So they are already listed in the plans as being able to support health in an evacuation centre or in a disaster situation as needed. And any requirement for health to attend will come to us through a liaison officer within an EOC, and then we'll pass any requests on from there. Very quickly as well, a few other agencies that you may see in a disaster situation in an evacuation centre. I looked at the Welfare Services Evacuation Centre plan, and agencies that support welfare services and are written into their plans include agencies such as Anglicare, Australian Red Cross, Salvation Army, Uniting Church. 54 Reasons I hadn't heard of before. They seemed like a great organisation, seeing the small blurb that was in the plan, predominantly around assisting with like children from memory. And Service New South Wales will also provide support to welfare. They're just a few that were listed in that plan, but there's obviously many other agencies that would potentially be in there as well to support the evacuees if it is an evacuation centre. So that in a nutshell is very quickly the role of health. Essentially, it's a coordination role for us. We typically don't deploy as much anymore as we used to. And we use supporting agencies such as St John and the Primary Health Network to do that for us so that we can continue to maintain emergency services and services within a hospital setting where need be. So thank you, Ellen.
Thank you very much, Josh. Next topic is the role of the Primary Health Network. By establishing the emergency register, we will have a list of providers who would be available for in-practice support and evacuation centre support in every region of our catchment, which means a quicker activation when a disaster happens, when the HASFAC, the local health district, activates the primary health network to coordinate primary health support and that response. So we also look after all the processes for deployment and post-event debriefing. When you register your interest, you will receive a questionnaire to fill out. You will receive a starter kit, which we will send to you. The handbook is available online. You will receive the handbook as a link again, just to make sure that you have a copy available. In the back of the handbook, when you look through it in the appendix section, there are actually some blank templates for record keeping, our go bags that are available. They contain prescription pads in case there are no other solutions available on the ground. So also some basic first aid materials. And another task we do is communication service availability, but also communicate needs that are seen by providers who assist in their practice or in the evacuation center. We would communicate those upwards to the local health district. Looking at activities, once you arrive in an evacuation center, especially in larger mass casualty evacuation centers, triage will be one thing that needs to be done in many instances. Another point is surveillance and early recognition of emerging healthcare needs, including infectious or communicable disease outbreaks, COVID, influenza, gastroenteritis, scabies. Then acute wound care is also one item you would look after. Wounds, animal and insect bites, lacerations, soft tissue injuries, eye irritations, inflammatory skin conditions, burns, rashes. We will have acute infections presenting cellulitis, upper respiratory conditions, including otitis media or externa, tonsillitis, lower respiratory conditions, including croup, bronchiolitis, community-acquired pneumonia, and infective exacerbations of asthma and chronic obstructive pulmonary disease, gastroenteritis, urinary tract infections, and so on. The list is long, but you see all of this in your practice as well. When it comes to chronic wound management, you might need to assist patients with dressing a wound, assessing it at first. Arthralgias might present, myalgias and gouts. Many people affected by a disaster will also display symptoms of mental health conditions. You might be required to provide mental health first aid, trauma-informed care, and there are options to refer patients to on-site mental health teams. Those can be LHD teams or then to community psychology. And as in any community setting, there will be pregnant women and young children, so antenatal care will be a topic. Feeding issues, especially during disruptions like evacuations, and the review and management of infants and young children. One hot topic in evacuation centers are prescriptions. People leave their homes, they might not take their medication with them. They might be cut off from home. They can't get back to get their medication. So there will be a large amount of patients requiring replacement prescriptions for their medication, just to provide the continuity of chronic disease management, that they can access and adhere to the medication, and also to prevent deterioration of pre-existing conditions. And then, of course, another reason for prescribing will be acute care needs, for example, antibiotics. And another item for in-scope activities will be referrals. Of course, if someone's unwell and needs to go to hospital, that will be an option to refer them to emergency department. there might be a need to refer them to other services within the evacuation centre, such as St. John's Ambulance if they need wound care. And there might be a need to refer them to other external services, such as a local operational GP practice, allied health providers, or pathology. There are also out of scope activities. So basically, anything is out of scope that does not fall within your comfort zone, because the general practitioners and their staff that assist in an evacuation center, we're aware that there will be a variation of skills. So the practitioner always decides what is within their usual scope and what service they feel safe to provide. Out of scope are also unsafe services, activities that would be unsafe in an evacuation center, like operations. You wouldn't do that. You would refer them to a hospital. High acuity care will still need a referral to the emergency department. When there's an emergency in an evacuation center, call 000, that an ambulance can transport patients to the hospital. And there might also be a need to refer patients who need specialist aged care to an aged care facility that's operational. Withdrawal management is also not in scope. Any substance dependence with withdrawal symptoms or prescriptions for methadone replacement. And then this is an evacuation center with an emergency setting, so you wouldn't want to see too many patients that require routine care that can be provided by their usual primary care provider if they're available. Also, probably out of scope, if it can be arranged, is the delivery of babies, unless that's what you do every day. But usually that would also be referred to a hospital to provide a safe environment. Fracture management that requires specialist intervention or plastering also will need to be referred to hospital. And I will now pass on to Ian McCarthy.
Thanks, Ellen. Welcome, everybody. Ian McCarthy, Disaster Manager for the Hunter New England Local Health District, speaking to you from Awabakal land. So what we're going to have a look at now is evacuation centre considerations, in particular from a public health focus, and Ellen has gone through some of those things that I'll talk about today, but we might just expand on them a little bit. So these principles are based on the Major Evacuation Centre Guidelines, which is a relatively new document that's out and available for you to have a look at. And I've basically just cherry-picked a reasonable amount of that document out and put it into some simple segments. So key principles. So first slide, thanks. So key principles: adequate provision of physical amenities and space is required to support the health and well-being of evacuees. This includes obviously access to clean water, hygiene, sanitation facilities and proper waste management. So, but when we're talking about major evacuation centres, we're not talking about a council hall or things along those lines, or even potentially an RSL club, which may be identified within the LMC process and through DCJ, Communities and Justice, as an evacuation centre. We're talking about facilities whereby it is more than likely that accommodation will be required. So people will actually be staying in these centres. Most of our centres to date have been essentially pop-up by definition, but are realistically a transit point for most people, in particular to register and then move on. So DCJ has the options and abilities through the Housing Contact Centre to get accommodation for people. So what we don't want to do these days is, if possible, have to accommodate people within a set space. So that's a big challenge. And if you look at the potentials for major evacuation centres across New South Wales, in particular for the Sydney Basin area, would probably be Sydney Olympic Park, ANZ Stadium. For the Newcastle area, it's more than likely going to be the entertainment centre. For Gosford, we're possibly thinking maybe around the Lisro area. There's a fairly large stadium or basketball area that could be utilised. For Tamworth, it could be something such as the Trek or the basketball stadium that's actually close by. So again, these are fairly rare situations and circumstances whereby we would actually need to accommodate large numbers of people for potentially elongated periods of time. And this is where the CEACON, as Josh was mentioning before, realistically comes in, because this is a whole of New South Wales type of an issue. It's not just a localised, concern. So public health advice is required, and it aims to minimise the risk of foodborne illness, animal and vector-borne diseases, and environmental exposure for evacuees. So we want to have them there. We want to have them safe. We want to have them secure, safe, with no concerns about their own safety or other people's safety. And we want to measure and minimise the risk of infectious disease outbreaks within evacuation centres. And some of those measures would have to be implemented, establishing protocols for disease surveillance, early detection and timely response, and some of those things that Ellen has already mentioned. So as Ellen also mentioned, access to prescription medication and primary health care is to be provided if required, and with a person-centred approach. Consideration of evacuees with chronic health concerns, mental health concerns, and people who use alcohol or other drugs. So going also just in relation to what Ellen was talking about, if it's identified that we have large numbers of people with chronic wounds or wounds of complex nature that do require anything above what is included in doctor's go bag or what they may consider to bring with themselves, we need to either refer them to hospital, or if possible, there would be consideration that we would actually deploy some chronic wound consultants from hospitals to go into that area to negate that issue, for them to be transferred to hospital for care. So we try and do that at the most optimal point, as Josh alluded to, at the lowest common denominator or the lowest point of care we can provide if possible. So next slide, please. Okay, ensure public health information and resources are accessible to the evacuated community, including translated resources and resources customised for disability. So that's really important things to talk about. Cold communities, so culturally and linguistically diverse communities, in particular, which, as we know, are also quite reluctant to go outside of their community, in particular to attend an evacuation centre where they potentially would consider to be marginalised with those areas. So we need to be very, very accommodating of those, including our Indigenous community as well, which do not historically they have a preference not to attend. So translated health resources are definitively available through the multi-health communication services. We need to include considerations, as I said, for responding to emergencies impacting Aboriginal communities in New South Wales, and including evacuation. And there's some New South Wales public health guidelines around that. So we talk about the guiding principles in this. This is a guideline 2024_004 when working with Aboriginal people communities. If anybody wants to look at that, they can have a look on the New South Wales Health website, and they can have a look at that guideline. Next slide, please. So location, access for provision of supplies and services. Obviously, we're going to establish a facility. We need to ensure that we can actually supply the services and supplies required to do so. And if you consider the say 500 to 1,000 people, the actual supplies and the logistics around actually managing that is quite significant, and not a task that should be considered lightly. Environmental infectious diseases, as we said, and disease risks posed by the location. So obviously we're going to try and minimise those situations. So mosquitoes, sandflies, etc. So that's a challenge. Accessible requirements of the evacuated population, and Ellen alluded to disability as well before. So that's really, really important. Wheelchairs and prams, etc. Layout. again, it's that division of the spaces. So essential living spaces for food preparation and eating areas, designated sleeping areas with privacy, space considerations, and bathroom facilities. And there is some very definitive guidelines around what we actually need to have in particular to toilets and hand washing, etc. I won't go through some of those there, but other importance is the special purpose areas. A pet area, and we use our agriculture and animal services for doing that, but we don't have pets inside the actual evacuation centre itself for the obvious reasons. Prayer room, creche, recreational areas, breastfeeding spaces are really, really important, and the associated requirements for that, sterilising of bottles along those lines. So yeah, intellectual disability and social safety requirements are really imperative as well, and it's up to the evacuation centre manager to particularly understand what's actually occurring with in their evacuation centre, and obviously things are going to be quite dynamic and have to change and progress as the evacuation centre evolves. We're not going to have all of these things set up straight away. It's going to evolve as a function and a facility as we move forward. Next slide, please. So I referred to toilets before. So the minimum standard is 1 per 50 initial phase of centre establishment, and with a minimum of 1 per toilet per 20 if it's ongoing. So obviously, if we're changing from a reception centre and a processing point to a full-blown evacuation centre with accommodation, we need to again to ramp up. So obviously, there's probably very few facilities that would have 1 toilet per 50. So we would obviously have to go through our emergency services partners and functional areas and increase the support for that. Toilet facilities should be no more than 50 metres from sleeping and eating areas for the obvious reasons. Cleaning protocols, hand washing, etc. So hand hygiene, absolutely imperative in these situations. We don't want to have outbreak of communicable diseases, and Ellen alluded to those before. Posters promoting hand washing should be visible, so again, for those particularly culturally, linguistically diverse people as well. Alcohol gel is fine, but there is a limit to how much you can alcohol gel your hands before you realistically actually have to wash them with good old soap and water. Showers, clean clothes, linen and towels, etc. How do you actually facilitate that? Well, again, through our health share partners, we've got the access to get into that kind of equipment quite quickly, and they would be vital to that. The challenge also again is those people from gender, non-gender specific communities, and the challenges we have with that. Again, it's up to that the facility manager to support and process those issues as we find them. Where possible, food is prepared off-site in a dedicated food preparation facility. We don't encourage people bringing their own food into centres for the obvious reasons, but again, that's challenging, particularly for culturally diverse groups who have a definitive preference on what they may want to eat. So again, 60 degrees for hot and refrigerated for 5 degrees or below, and our public health partners within New South Wales Health would be supporting us, and also councils through their functions of their public health arm would be supporting us in ensuring that those protocols are adhered to, because it's quite quick that a foodborne outbreak would occur. So again, allergens and minimise the risk of cross-contamination during food preparation and serving. So really challenging things. Routine management of infectious diseases, as we said before. All evacuees should report to the centre management upon entry or onset: fever, cough, cold-like symptoms, vomiting or diarrhoea, rash. Medications, I think Ellen has certainly spoken about that before earlier, and they're really challenging. So, the issues around people not bringing their medications or having poor access to them. Contraception is another one, and certainly is a highlight that I saw in there is, we do need to consider those things ongoing for these people in particular don't have their medications with them, and I guess generally that's not something you would carry with you on a day-to-day basis. So very important. Next slide, please. People with pre-existing mental illness may be at increased risk of experiencing symptoms of mental illness and acute distress in the aftermath of a major adverse event, and there's no doubt about the fact that we need to identify that, and we need to provide in situ support, or we need to give people the ability to actually seek their own support. Our partners through the telecom and communications network would more than likely be setting up a mobile link within the evacuation facility to probably deal with the bandwidth increases that may be needed with those large number of people in that area. Football stadiums should not be too bad because obviously they're quite used to having large numbers of people utilising mobile devices at any time, but things such as the track or a basketball stadium might not have that infrastructure available for them. So we'd be again leaning on our partners to support that. And I think there's just today I noticed that Jihad Dib, the New South Wales Minister for Emergency Services, actually put out some very impressive guidelines and some new news on the availabilities of communication devices through New South Wales government. So that's great. Smoking and vaping, that's of concern, obviously. In New South Wales, it's banned in all enclosed public spaces, but we do need to recognise the fact that that will be an issue, certainly for people going into an evacuation centre. Next slide, please. Agriculture and Animal Services, or ASFA, as we mentioned before, led by the Department of Primary Industries, coordinates support of animal owners, carers at evacuation sites. And we recognise the importance of people and their animals and the stress that's actually created by them being separated for them. So, that's really important. And essentially along the lines with DCJ, the preference is that we don't have, or the definitive is that we would not have animals within an evacuation centre, but we need to allow scope for people to have access to those animals and look after them. So animal safer places may be established. If animals are on site or evacuees attending to animals at an ASP, regular hand hygiene must be promoted, obviously attaching animals, food supplies, etc., and cleaning up their waste. Again, we need to make sure we don't have disease outbreak as a result of that. And the last but not least, public health services are to offer evacuees returning home information and guidance to minimise health risks associated with the aftermath of a disease. So it's not just the care for these people whilst they are at the evacuation centre. We need to have a very definitive consideration about what happens to them when they leave. How are they going to leave? By what mechanism? How did they get there for a start? Was it bus? Was it train? What's going to happen to them? How are they going to get home? What's home actually going to look like? Are there any risks associated with them going back to their house? Has that house been inundated, for example, by floodwater or impacted by fire? Or is it structurally not being compromised due to, say, for example, earthquake, those things. So again, we need to make sure that people are very conscious and aware of what they may be going home to, and also make sure that they have the ability or the understanding of in the post-disaster phase and their post-returning to home, that there are mechanisms by which they can talk to people, fact sheets to support them in returning home, and in particular around how they would clean out their house, what they would do from a waste perspective. So it's actually quite a complex thing, and it's realistically from the time that they, as I said, from the time that they arrive into the facility until the time they get home. So it's a challenge. The reflection back, I guess, though, onto a small evacuation centre at a facility like, I don't know, Condobolin or Denman or Merriwa or something along those lines. Generally, it would not be an overnight stay. There might be some people that do stay in these facilities, but that's not our desire to have that happen because it places too much pressure on them. Some people, however, do elect to stay in their cars because they are safe. So again, that's another thing that we need to consider. And again, we need to consider the security of that area, whether it be by police or by private security. So in the large evacuation centres, obviously police being one of our significant emergency management partners, then they are there in presence. But in a smaller one, it's something, again, that we need to consider. So that's about it for me. Thanks very much.
Thank you, Ian. I will hand over to Josh, who will share his experience with us when he worked in an evacuation centre. Thank you, Josh.
Thanks, Alan. For those that may remember, quite a number of years ago, back in 2011, early 2011, Queensland had significant floods in the Brisbane area along the Brisbane River. At the time, I was a volunteer with St John Ambulance in New South Wales, and I was part of the first contingent that flew from Sydney to Brisbane to support the St John Ambulance in Queensland that were there. And I was posted at Ipswich Showground, which was utilised as an evacuation centre. If you just go back quickly for me, Ellen, sorry. It's just a quick overview of the showground itself. We were primarily operating out of the main sort of racing club, which overlooked the racetrack, where that red marker is. That's where we operated our first aid post from. That's where the meals were provided by the Salvation Army in that location. And we also had some of the more vulnerable community as well were sleeping in that building as well, so we could oversee them a bit more at night time and during the day, those who were less mobile but had medical conditions that needed to be monitored. The remainder of the evacuees were located in the bottom left-hand side of the screen, that snapshot, in the indoor centre. So some of that was open space, and some of it was for those that have played indoor sports before, was still netted and had indoor fields within it. So people were sleeping inside those indoor fields as well on camp stretches. And then we had sort of in that middle section, we had some other services there as well. We had a bank came and dropped off a shipping container to utilise as an ATM facility. And their equivalent of Centrelink and those sorts of other agencies as well were also operating at the top as well. Thanks, Ellen. So a couple of pictures in the next slide. But what I really wanted to focus on in this one was we went up there. The local St John crews had been operating for about 4 or 5 days, 24/7, and were absolutely exhausted. So it was great to get some fresh legs on the ground, but we were also restricted by what we could do. As we were from New South Wales, we had a different scope of practice to Queensland. It may sound very basic, but our scope included things like blood pressures and blood glucose levels, which weren't yet in the Queensland scope at that point in time. So we were able to do a few extra things, but the real game changer was when on day 3 of our deployment, we actually had a local GP attend and then be able to offer services to our evacuees there. And particularly it was around, as we've mentioned, Ellen's mentioned it, Ian's mentioned it, it was around prescription medication. At the time, prior to that, there had been very little ability for evacuees to get their prescription medication. We were doing lots of daily monitoring or multiple times during the day monitoring of blood pressure of some patients. Anything that was donated through the community, lots of food parcels and those sorts of things, but any sort of medication, over-the-counter medication that was donated, we would immediately take and stockpile ourselves. So we had a good stockpile of Panadol and kids Panadol and those sorts of things. But when it came to the prescription, it was a real game changer when the GP started having their service there. We were there for a couple of days. They had certain hours that we knew they would attend, and we'd have patients lined up ready for them to be seen. We then had a local pharmacy that was then able to do pharmacy runs for us. They would come in at a particular time, collect all the scripts that have been written by the doctor, and take them, fill them, and bring them back a couple of hours later. So that was a huge difference for those evacuees to be able to start getting their regular medications back again and return to some sort of normalcy, even though they weren't within their homes. And after we left, the second contingent was there, and where the benefit of the doctor came in then was when they started returning to their communities and tidying up their homes, but still having nowhere to live and returning to the evacuation centre. The GP was able to do some minor wound care, but also things like tetanus shots, which was a big risk, returning back to floodwaters and getting, scrapes and sticks from debris that was still lying around. So whilst we did a great job as a volunteer agency, the real big game changer I feel was having that GP support and that additional skill set that wasn't available in that sort of first responder type of deployment that we had. So just a bit of lived experience from a number of years ago. So thanks, Ellen.
Great. Thank you so much, Josh, for sharing that experience. I'll just quickly touch onto the post-event debriefing. So once your assistance in an evacuation center has ended, PHN will touch base with you to debrief. We will discuss what was planned, what actually happened, what went wrong, what worked well. Was the operation sized appropriately? Did the command and control structure work well? We will tell you also, show you where you can access additional support. That can be the mental health support via the Primary Health Network, Members Assistance Program, and other sources. And then also confirm the claimed hours for the reimbursement of your time. There's also an element of training involved. When you express your interest, you will receive a list of options. Most of them are online based. It's about the emergency management training. New South Wales Government has their capability hub, and they have 20 plus courses you can take about emergency management, EOC, the Emergency Operations Center concepts, risk management. And I will quickly hand over to Ian because he will talk about the content of a mini-MIMS. When you fill out your EOI, you will be able to express your interest for a mini-MIMS course organized by the local health districts and the Primary Health Network. And once we have enough participants together, we will be able to provide that course. Ian, the contents of the course, please tell us about them.
Thanks, Alan. So look, I guess for those that haven't had previous exposure to this, the MIMS course, or the Major Incident Medical Management Support course, is one that's provided on a single day level and a 2-day level across New South Wales Health. Primarily, the 2 days are run in Sydney by the State Preparedness and Response Unit, but the 1-day courses are run within New South Wales Health LHDs by individual people who have the experience and the qualifications to actually provide that course. But what it does do, it reiterates and reaffirms in particular what Josh mentioned earlier particularly about combat agencies and functional agencies. It goes through the emergency management arrangements for New South Wales in quite clear terms, and particularly from a health focus. But what we also do in that course is we actually teach and educate against what we call mass casualty triage. And these are one of that's probably the underpinning and the foundation of this training is this mass casualty triage and response process. So if you're not familiar with the mass casualty triage principles, you can have a look at the SMART triage principles, and you can Google that. But what it basically does provide you that understanding of what actually happens in that pre-hospital environment. It supports you and guides you through that pre-hospital experience, and going back to what Josh was mentioning around the responsibilities, in particular of emergency management agencies. So it's quite a comprehensive course. It's easy to understand. It's simple language. But if you haven't had exposure into the health system, i.e. into emergency departments for quite a few years within your practice, then it's something that's probably you're not necessarily familiar with, or you may have not necessarily forgotten about it, but probably things have changed significantly. So we're certainly keen to provide this, and we'll be continuing to speak with the PHN in relation to this. But I guess it's about trying to elicit and understand some support. Going back though to what Ellen was saying about EM training, New South Wales got the resources. Really important for you to understand how and I guess how and why and what works within the emergency management arrangements, because a lot of it is acronyms that unfortunately become confusing and quite challenging. And if you've got some prior understanding of that, it's really quite vital to, in particular, the way that Josh and myself speak on a regular basis, and people just get confused and lost within it. So it's really great to do that kind of stuff, that training, simple and no issues online. Thanks, Alan.
Thank you, Ian. And to wrap this up, summary, have a look at the handbook. It's not too long, but it still explains all the important items in detail, that there are, I hope, no more questions left at the end. So if you're interested, I can only say I encourage everyone to think about it and to express their interest. It's available, the link in this slide, but also on our Primary Health Network website. If you have questions, if you have feedback, or if it's running feedback after an event happened and you want to let us know what we could do better, please reach out. These are the contact details. And there's also a limited opportunity open at the moment for a position as a GP advisor to the Primary Health Network Disaster Management Team. That's a position on an hourly basis only. So have a look at that one as well. Now, I will hand over back to Sydney, who introduced the sessions, for any questions that the audience might have. Thank you very much.
Thank you, Ellen, Ian, and Josh, for all of that information. It was wonderful. Now, Ellen, I can see that no questions have come through yet, but I believe that you had one question that needed to be asked as well that you received.
Yes, I received a question a while ago from a provider asking, once I'm on the emergency register and an event happens in my region, but I'm actually away on leave or I'm not available during that time because I'm affected myself. How does it work? Do I have to provide assistance? The answer is no. It's voluntary. You can unsubscribe at any time. So we will check your capacity with you before every single support, maybe in practice support or the evacuation center support. So it's very flexible support.
Great answer. Now, the PDF from today is already up in the materials section in your control panel. So if you do want to take that information away to register your EOI, please do that today. Again, the evaluation will come to you shortly. Oh, we did get a question come through. Yay. What sort of disasters are expected within the PHN area?
So our area, as big as England, it's huge, is prone to almost all disasters on the list. Maybe not the winter events, but we have most likely, we will deal with floods, with bushfires. But we also have to factor in events with a lower likelihood, like an earthquake or a tsunami. We did have a mass casualty event only recently. We will have severe weather, which is very likely to happen as well. The list is long. So yeah, that's a really good question. Thank you.
And then another one, is there any scope to have a local practice run of how to navigate, how to manage a disaster? It's hard to conceptualize when you have not ever been involved in a disaster.
Yeah, sure. So please reach out if you want to run through the activation process or how it would all happen once you have submitted your expression of interest. We can talk through all the different steps and walk through the handbook, answer every question. Does that answer your question? Or was it more a practice, business continuity, preparedness type of question?
I'll wait for a response first.
Yeah.
Both good questions. And if we don't get a response, we can definitely reach out to you one-on-one and just, yeah, we've got the questions and emails, so we can definitely get back. But I'll just wait to see if they respond to that one and see if that one was answered. And then also just a reminder, I will upload your CPD hours as well. And I will do that shortly. And now the response, more with all the various people involved, really.
With staff members of your practice, we can run through that as well. If you wish to take staff members into an evacuation center or want them onboarded on the whole thing as well. We won't have test runs for practice involvement in an evacuation center. However, if you're interested, please send me and express your interest, because I can bring that up with the local Department for Communities and Justice when they have their next evacuation center exercise on a local level. I can ask them if the practice would be able to attend. That's an option.
I think that might have, that answered it. Perfect. Thank you.
All
for
right.
that.
Thank you. All right.
We are a little over time, so we will wrap up for today. But again, any questions, there was the email there, and you can take that PDF with you and get in contact with Ellen at any time. And thank you again, Ian and Josh. Hope you all have a wonderful night.
Thank you so much, everyone. Have a good night.